Good morning. This is Sam Abel-Palmer, and I'm joined by my colleague Marilyn Mahusky. We are attorneys at the Disability Law Project at Vermont Legal Aid, and we are going to be talking today about assistive technology, in particular funding assistive technology for children. This is an issue that we've certainly both seen quite a few cases about, and sometimes it can be a pretty straightforward process, but sometimes it can get quite complex. And so we wanted to kind of walk you through some of the basics of how you make requests and what the standards are for qualifying for funding for assistive technology, in particular in both the Medicaid context and in special education. We'll talk briefly about some other kinds of funding sources, but the two primary ways that gets done are through Medicaid and through special ed. First thing I wanted just to do a quick look at is just the basic definition of assistive technology. What you see up on the slide here is the definition of assistive technology from the special education regulations, and as you'll see, it's pretty broad. There are actually two definitions. There's an assistive technology device, which is the actual physical thing that you're using, which is really any item, piece of equipment, or product that is used to increase, maintain, or improve the functional capabilities of individuals with disabilities. So really, it can be anything, technically, from a specialized pencil holder to the most complex piece of high-tech machinery that you might be using. So it's very broadly defined, as long as it's a thing that can be used to assist somebody and improve their functionality. And then an assistive technology service is anything that a person does to help either obtain, evaluate, or keep functioning the piece of assistive technology equipment or device. So anything, and that includes training. I think that's an important thing to keep in mind, is that not only does this assistive technology include just the thing itself, but somebody to teach you how to use it and making sure that it's being functional and evaluating how well it's working. On the there really isn't an equivalent definition on the Medicaid side, and in fact, the Medicaid law doesn't even really use the term assistive technology in the same way. What you'll see in Medicaid law is discussions about durable medical equipment, but that's often an equivalent to assistive technology, although not exactly. But more often, it really just, they'll define it in the regulations by the type of equipment that's being used, and so that it's just not as clearly set up in the regulations around Medicaid. However, especially for children, there is an equivalent broadness to how assistive technology is used. I've recently had a situation where we were working with Medicaid on coverage of a fairly complex speech-generating device. But certainly wheelchairs, specialized medical equipment, really, again, almost anything that's going to be fit into that kind of definition. We just actually had a question. I was actually made aware of this question before, about talking about whether there's sign language training for parents and whether that qualifies under assistive technology. Anything that related to sign language, in particular in a school situation, because that's a service that's being provided by an individual, that isn't specifically covered under assistive technology. It can be a related service for a person, especially a child with a disability, in a school setting. But because it's not being provided by an individual, being provided by a piece of equipment, it's not assistive technology per se. There are certainly provisions for having sign language support and potentially even training for teachers or parents under special education, and that could be covered, but it wouldn't be covered as assistive technology. It would be covered as a service, related service under special education. So if we go just to the next slide here, just wanted to list specifically funding sources. So as I said before, Medicaid and EPSDT is early and periodic screening, diagnosis, and treatment. That's basically what that means is children's Medicaid. It's a separate set of standards for Medicaid recipients up to age 21, and it's more broad and inclusive than adult Medicaid, so more can be covered under EPSDT. Special education is the other major funding source for assistive technology, but there are sources around, you can get private insurance to cover. In fact, that device that I talked about, that speech-generating device, was covered partly by private insurance, partly by Medicaid. So some private insurance will cover some assistive technology, though generally not as expansively as the other sources. Voc Rehab is often a very good source, including for children. Voc Rehab can participate in school settings, and if there's something that is needed to help a student train for an employment situation, that may be fundable under Voc Rehab. Certainly once they turn 18, maybe not before 18, but Voc Rehab might even consult before then. And then there are community resources. We listed a website called getatstuff.com. This is kind of an exchange informal marketplace for trading assistive technology devices. But there are other, certainly other places that you might go to for funding as well. We're now going to switch focus specifically to Medicaid, and I'm going to hand things over to Marilyn.
Thank you, Sam. I'm going to focus my talk on the Medicaid funding and the Medicaid program. And for people who don't know, although I imagine many do, Medicaid is actually the nation's largest healthcare service. It provides medical assistance to children and adults whose income and resources are insufficient to meet the cost of necessary medical care. It includes coverage for people who are aged, blind, and people with disabilities. And in Vermont, we often refer to that as the Katie Beckett waiver, which is simply a waiver of parental income and resources in establishing Medicaid eligibility for children with higher level of need. The primary goal, and I put this in here in part because I think it's relevant to the AT issue, which is that the goal of Medicaid is, and this is in the introduction to the statute, the federal statute, is to provide rehabilitation and other services to help recipients attain or retain capability for independence or self-care. And that is a driving force in Medicaid law, and certainly a driving force in terms of accessing assistive technology. Medicaid provides a package of both mandatory and optional services. Every state develops its own package of services, and once a package is developed, then all of the services must be provided to eligible recipients. So what I say often is that Medicaid is Medicaid is Medicaid. If you qualify for Medicaid in Vermont, then you qualify for all of the services if you are a child. And as Sam pointed out, there are different requirements for adults and children, or actually there are different services that may be available if you're an adult and if you're a child. But when you're under the age of 21, Medicaid is considered an entitlement, so that if you qualify for Medicaid, you are entitled to the full range of services that are available to Medicaid recipients. So these next couple of slides, and there are quite a few of them, so if people are listening later, we have some of these we are just going to skim right through, but I put them in because I think sometimes it's helpful, I know when I'm listening to a webinar, is to have access to more information so that if I want to go back later, I can refer to things and have a better understanding of what I'm talking about. But Medicaid covers services. So when Sam mentioned at the outset that there is no equivalent definition of assistive technology in the Medicaid context as there is in the special ed context, it's because Medicaid covers, provides covered services. It provides access to medical assistance, which can include things. So for example, under various categories of covered services, you may be able to access certain as Sam said earlier, the definition for AT in the special ed context is things. So the options that AT might be covered under federal law are listed here. One might be home health care, which supplies medical supplies, equipment, and appliances suitable for use in the home. You might be able to access services under the PT, OT, and speech therapy services, which include supplies and equipment, prosthetic devices, and then sort of the catch-all, which is rehabilitation services, which includes any medical or remedial service for the maximum reduction of physical or mental disability and restoration of the beneficiary to his best possible functional level. So looking to the next slide, Vermont has its own categories, and some of them mirror but differ in respects from the federal law. And the primary categories for funding assistive technology in Vermont are these that are listed. Obviously, pharmaceuticals isn't assistive technology, but it is listed along with medical supplies and equipment, which would be similar to the home health option under federal law. Durable medical equipment, as Sam pointed out, which is sort of, when we talk about Medicaid funding of assistive technology, primarily we're talking about durable medical equipment. Wheelchairs, mobility devices and seating systems, augmentative communication devices and systems, and prosthetic devices. And what I've listed here is the M7504. What that refers to is the Medicaid covered services rules. And at the end of our materials on the resource page, there is a link to the Medicaid covered services rules. So if people are doing research, they can link directly to those rules. So let's hit the first slide. I'm not going to go into all of these, but I think the similarities between all of these, or among all of these various categories, is that in the Medicaid, in Vermont Medicaid regulations, which is what these Medicaid covered service rules are, is a definition of the category of covered service. So in this instance, medical supplies and equipment. It defines what they are. They're non-durable items, customarily used in conjunction with care or treatment of a specific illness, injury, or disability. And then it lists under the definition the pre-approved list of categories of covered items. And I've listed just a couple of them, and there are many under this list. So each of these categories of covered services include a list. And it's important to know that the list is not exhaustive. It does not include everything. So if a provider is, if a child is identified as having a need for a particular item of assistive technology, and it's not listed, that shouldn't be a preclusion from going ahead and applying for the service. The next slide is the durable medical equipment slide. So this is equipment that will arrest, alleviate, or retard a medical condition. It's used primarily and customarily to serve a medical purpose. It needs to last and withstand repeated use. It's generally not available to people in the absence of illness, injury, or disability, and this is really important. It's suitable for use in the home. That doesn't mean it's restricted to use in the home, but it does mean that it needs to be appropriate for use in the home. And it looks like we have a question here. All right, so this question I think we will address later in the presentation when we're talking about special education. And in terms of the Medicaid context, the question is, who determines what kind of advice is best? And obviously a professional of some sort. So we'll discuss that later in the Medicaid context and again in the special ed context. Here again is a list of some of the pre-approved lists of covered DME. What I thought was interesting when I went back and looked at the list is that some of the examples of covered items are also included in the list of non-covered items. And I will talk later in the presentation about the exemption provisions, which is a process by which you can ask that Medicaid cover something that's not on a pre-approved list. So here's some of the big examples: the car seats for children with special health needs, special adaptive drink containers for infants, a bathroom scale for somebody who looked at that one, for somebody who had heart condition, air conditioners, you know, that's typically one that's on an excluded list, but under certain circumstances, air conditioners can be covered, and of course wheelchairs, but that has its own separate category as well. As I mentioned, the list is not exhaustive, as is the case for all of these covered services. But one thing that is somewhat universal is that all of these assistive technology devices may require prior authorization, which means that there is, we'll talk about that later, the process for getting pre-approval for the device. In the durable medical equipment, there's also medical necessity tests, and we'll also talk about medical necessity in a few minutes, is that the DME must be necessary to avoid bed or chair confinement, so there's sort of a tag along there. Medicaid will also cover repair of DME, and the other principle that runs throughout all of this is that in order to obtain the actual device, the provider must be a Vermont Medicaid provider. So in other words, you can't go to the computer store and buy your child an iPad, which could be considered an assistive technology device, unless that store is also a Vermont Medicaid provider. Here's a list of the definition for wheelchairs, mobility devices, and seating systems. I'm not going to read through this. I'll let people skim through that themselves, but essentially mobility devices enable people to have mobility if they're unable to ambulate by other means. It includes wheelchairs, seating systems, and it also includes customization when that's necessary for the individual. Again, a pre-approved list. Prior authorization is required. It includes repair and replacement. I think one of the myths about Medicaid is that there's a limit that you can only get one chair a year or one device, but actually there is no prohibition along those lines. Rather, a chair or other piece of another mobility device could be replaced if there's documented growth needs. So, for example, with a child, if there's a change in the individual's medical status, which would necessitate replacement, if there's loss, or if the chair or device no longer safely addresses medical need. Looking at the questions, the question online is, can you have a backup chair? And the answer to that is no. You can have an electric chair and a manual chair if your condition requires it under certain circumstances, but in terms of a backup, no, is the short answer. In some instances, particularly with wheelchairs and mobility devices, Medicaid may determine that it's cost-effective to rent as opposed to actually purchase the device, and so people ought to be aware of that. And there may be circumstances when a device is rented for a period, a trial period, and then purchased. Again, it needs to be provided by a Medicaid provider. And this is something that I didn't know. Under federal law, for years, we understood that under Medicaid, and this we thought was the difference between Medicaid and special education, is that the equipment belonged to the individual. But that is not the case under these several of these provisions, which is that the equipment is actually owned by the department. So if you no longer need the chair or mobility device, there are requirements for either returning that or some other way of disposal. Here's a big one, I think, for children, which is the Augmentative Communication Devices and Systems. And this is very broadly defined. So an augmentative communication device or system transmit or produces messages or symbols in a manner that compensates for the disability of a beneficiary with a severe communication impairment. It's provided, and this goes to the issue of medical necessity, is when the impairment prevents writing, talking, or telephone use. And it will only be approved if it meets a specific medical objective or outcome. And we'll talk in just a few minutes about medical necessity, but those are all requirements or elements that go to that standard of medical necessity. Again, there's a pre-approved list. It is not exhaustive. And I've just listed a few of what the pre-approved list includes, but it includes laptops, microcomputers, softwares, assistive keyboards, scanning devices. It's really, as I said, quite broad and can be very helpful for children in particular who have disabilities. In addition to providing the device for Augcom devices, Medicaid will cover modification, programming, and adaptations of the device when it's provided by a qualified speech-language provider, which I think is important, particularly because so many of these devices can be complicated and need that kind of service available to be able to use it appropriately. Again, you may be required to rent it or have a trial rental period, and there may be some requirements that the individual demonstrates that they're actually able to use the device and benefit from the device. Again, prior authorization may be required. The device belongs to the department, and it must be provided by a qualified Medicaid provider. All right, I'm not really going to talk about this, but prosthetic devices, again, is, replacement corrective or supportive devices when there are body parts that may be missing or need to be replaced. Again, they're, the list of what some of the services are that are covered under prosthetic devices are listed, and you can peruse that at your leisure. So how do you access these? The question earlier was, who determines what you need? And I'll talk about that in just a minute. But in order to obtain an assistive technology device or service under Medicaid, the first thing you need to do is determine whether or not what you're looking for, the device or thing that you want, fits within one of the definitions of covered services. So, as we just listed, we talked about the categories of covered service in Vermont: durable medical equipment, wheelchair, AC device, prosthetic device, or medical supplies and equipment. So the first thing is fitting the device into a Medicaid covered service category or Medicaid box. The next issue is medical necessity, and this is really the key. This is what defines eligibility for Medicaid. In Vermont, and actually across the country, Medicaid for medical necessity for children is defined very broadly. I've included both the federal definition and the Vermont definition. I've included the federal definition because it's broader, I think, than the Vermont definition, and in any appeal or controversy, one could rely on the federal definition. And basically, under the EPSDT standard, medical necessity is any service necessary to correct or ameliorate physical and mental illnesses and conditions. Congress has repeatedly, in reauthorizing EPSDT, has focused on its preventative thrust, which is particularly important for children. The other important criteria about the EPSDT standard is that the service needs to be medically necessary, so any service necessary to correct or ameliorate. And that includes anything that could otherwise be covered by Medicaid. So even if it's not on Vermont's plan, state plan for medical assistance, and it's provided elsewhere for covered by Medicaid, it could be covered by Vermont Medicaid. So I'm going to stop for just a second and look at some of the questions here. One of the questions is a school-based speech-language provider considered a qualified Medicaid provider? It could be. The speech therapist could be a qualified Medicaid provider. There would be two ways. One is if the individual were either qualified as an individual Medicaid provider or associated with some other entity like a mental health agency or a hospital or some other entity that's a Medicaid provider, but schools can also become Medicaid providers. So if the school is a Medicaid provider, and most schools, I believe, are Medicaid providers, so that they can bill services, and Sam will talk more about this, is some of the interplay between Medicaid and special education, so that certainly speech services can be provided under education, special education, and or Medicaid. Another question is does Dr. Dinosaur fall under these Medicaid definitions? Absolutely. Remember what I said at the beginning, Medicaid is Medicaid is Medicaid. If a child qualifies for Medicaid, it doesn't matter the means by which he or she qualifies. Once you have Medicaid, it's Medicaid. Okay, so then there's a question about the AC devices and whether or not they apply to children. You need to go back and look at the particular category of coverage, but I believe that in Vermont, the AC category covers adults as well, but there would be a different medical necessity standard. So you would use the standard that's defined in Vermont Medicaid law, which is, I believe, 710. M7102.
And the bar is pretty high.
And as Sam is just saying, and the bar is pretty high for that, for adults. For children, again, it's a very broad, very comprehensive standard. Another question here is, if a family is hanging onto equipment that their child has outgrown and Medicaid has paid for, who would you contact about this? The family should contact the Medicaid division. And they would be able to let them know how they can dispose of or give those pieces of durable medical equipment to somebody else who might need them. Okay, I'm not going to read the Vermont EPSET standard, but as I said, it's not quite as comprehensive, and I think in a conflict at a fair hearing, you could use the broader national EPSET standard. So the next slide here, we're going to focus on prior authorization for just a few minutes. So in order to obtain an assistive technology device or service, typically there would need to be some sort of evaluation. And Sam will talk about how one obtains evaluations in the special ed context. But you would need to have an evaluation by a physician, by an OT, a PT, a speech therapist, and once a device has been determined appropriate for the individual by that provider, the physician, the OT, the PT, they would have to go through the prior authorization process through the Department of Vermont Health Access. And the purpose of this is to, one, assure that the need for the device is medically necessary, that it meets a medical purpose, and that in the kids contest it's necessary to correct or ameliorate a medical or physical condition. Vermont Medicaid will look at whether or not the alternatives have been considered and whether there is an appropriate, less expensive alternative. Less expensive doesn't mean least expensive. Again, it needs to be medically necessary and it needs to be appropriate for the individual. And finally, they'll look at whether the device is typically provided within the practice parameters of that practitioner. So, for example, is it something that would typically be provided by an OT or a speech therapist? So, going on to the next slide, how do you make this request? Well, one, it needs to be in writing. The providers will have complete, claim forms. There'll be a medical necessity form. As I said earlier, it will be made by a qualified individual, whether that's a physician, an OT, a PT, a speech therapist. It might be done by a hospital, rehabilitative service. And the request is made to Vermont Medicaid. And Vermont Medicaid may ask for more information. They may ask for a written plan of care, treatment goals. They'll want to know whether there is a reasoned opinion in support of medical necessity. And this is really important, that the provider who's evaluating the child and determining what device might be appropriate for use by a child needs to be able to back it up. And they need to be able to provide an explanation for how the device is going to do what you need it to do and that it's actually meeting a medical need for that child. If it's a mobility device, it's going to help the child ambulate. If it's an Augcom device, it's going to address the issue of communication. So that's really important that it be fairly detailed and that that it be supported. And then I think it's also helpful, too, if in that written request there's a statement of the alternatives that were considered and the reasons for rejecting them. Because when that request is made to Vermont Medicaid, they are going to look at that, and there may be a lot of back and forth between the provider who's writing the prescription for the service and Vermont Medicaid, because they will look at some of these very carefully. There is a question here that I'll just address really quickly. Do you have a resource for finding out more information about Medicaid coverage for AC in adults? Well, there would be the
medical. Just get a letter from the doctor.
Yeah,
make the request.
What Sam is saying, you know, you same process. The prior authorization process would be the same for an adult or a child. Is that you would have an assessment, medical necessity would need to be established, and you'd make the request to Vermont Medicaid for coverage. Okay. So once a request is made, a prior authorization request is made, the department has 28 days to issue a response. That used to be 30, but that's been reduced. Not really quite sure why. But the request is made of Medicaid. They have 14 days from receipt of the request to make a decision. That can be extended for 14 days if more information is requested. And as I said, oftentimes with these devices, Medicaid may ask the provider for more documentation to establish medical necessity and to establish that there are no less appropriate alternative, less expensive devices. So let's talk for a minute about the coverage exemptions. So what I said earlier is that there are these pre-approved lists, but the lists are not exclusive, they are not exhaustive. And in the Vermont Medicaid regulations, there is a provision that applies both to children and adults called an M7104 exemption process. And what this is a mechanism by which you can request coverage for an item or device that's not on a pre-approved list. So because, you know, under EPSCT as a child, the list arguably is much, much broader than it would be for adults. So if there is, because of new technologies, new developments, there may be all kinds of devices that are not on the list. And so there is a mechanism for requesting coverage. And it's really quite simple. A written request to the director of DEVA. He or she makes a decision within 30 days. And there are 4 possible outcomes. Either the request is approved for the individual and added to the list. It's approved for the individual but not added to the list. It's not approved for the individual, probably because it's not medically necessary or it doesn't meet their needs, but it's added to the list, or it's neither approved for the individual nor added to the list. And that's an important exemption to remember, is that you don't have to take no for an answer, I guess is the short answer. And here is just a list of some of the examples of things that have been covered through this exemption process that previously were not covered and not included on a pre-approved list. So don't take no for an answer. What's your remedy if you make a request for a Medicaid device or the device, the request is not acted upon promptly? So remember I mentioned the 28 days for prior authorization request decisions and 30 days for the M7104 exemptions. If it's 45 days and you haven't gotten a decision, that would be a time within which you could file a request for a fair hearing. The fair hearing request should be made in writing. It's made to the Human Services Board, and I have contact information for that on the back. Prior to making a request, you will receive a notice of decision. The notice of decision should be clear. It should explain the reason for the denial. It should cite to the regulation that supports the basis for the denial. And this is important because we have found over the years that Medicaid notices can be less than clear, and people aren't understanding why the device or the request or the Medicaid service is denied. And it's hard to appeal something if you don't know what the explanation is. When you make that request for a fair hearing, you're entitled to an impartial hearing before an impartial, hearing before an impartial hearing officer. You may be able to get an evaluation, although I don't know how frequent that happens in these instances, but certainly you have, you can request that sort of an independent evaluation. And then the hearing officer can make a decision within 75 days. So it's important to appeal decisions, have your medical evidence in order, which would include, support from your Medicaid provider, whether that's an OT, a PT, or a physician. So with that, I think I will turn this over to Sam, who will talk about AT and special education.
Thanks, Marilyn. So, as in most cases, I think, as Marilyn is explaining, the coverage of AT under Medicaid can, especially for children, can be very broad. The coverage under special education can be quite comprehensive, but it's limited in some very specific ways that I think are important to understand when looking at the dynamic of, to decide, do we ask Medicaid for this, do we go to the school to try to get a particular device? Schools have a basic obligation to provide AT that's necessary to provide, and this is the catchphrase for all special education, a free, appropriate public education, FAPE. That's the bottom line standard for any decision in special education, is the school has to provide this free, appropriate public education. If the AT device is necessary to provide that, then the school has an obligation to provide it. But because of that, the school is only required to provide things that are related to educational goals rather than medical goals. And this is often the biggest gray area, especially for children. What's an educational goal versus what's a medical goal? They do tend to overlap, and it's not always very clear-cut which is one and which is the other, especially for very young children. Learning how to eat properly, being able to eat food without choking, can be both a medical issue and an educational issue. For older children, that's less likely to be an educational issue, though for certain medical conditions it might be. It's always going to be done on a case-by-case basis. But the school is only obligated to provide things under an educational goal, and sometimes the school will say, well, that's not educational, that's medical, go talk to Medicaid, and the school might refuse on that argument, and then you would have to come back and say, no, this really is related to an educational goal. The other big difference is that just on a legal standard, schools do not have the same kind of broad-based requirement to provide the best possible function that Marilyn talked about under EPSDT. That's a very generous standard under Medicaid. Schools are only held to the free appropriate public education standard, which there's been a lot of court definition around this, but basically what that means is that the service has to be adequate and reasonably calculated to provide some educational benefit, but it does not have to provide the best service. And so schools often have a much lower standard that they have to fulfill before they meet their legal obligation. Question that came in: what would AT have to relate to IEP goals, or could it be used for students with a 504 plan as well? Absolutely, it could be under 504. 504 is the non-discrimination law related to actually any entity that receives federal funding, but especially for schools. And yes, assistive technology can be provided under a 504 plan, and the school may have the same obligation under that 504 plan as it has under an IEP. The IEP is going to be more specific and often more detailed in what the school is obligated to do, but there's nothing that prevents a school from having to provide something under a 504 plan. So that certainly is an area where AT can be provided.
We'll talk about that later.
Okay, and we have another question, but I do want to probably get to that a little bit later. I want to get through some of the basics here on AT and special education. So what is assistive technology under the IDEA. IDEA is the Individuals with Disabilities Education Act. And what I've put here is really that same definition of assistive technology or assistive technology service. Any item that improves functionality can be assistive technology, but does not, and this is specific in special ed rules, does not include a surgically implanted device. Schools are not required to provide surgery to students, but it can be a hearing aid if it's an external hearing aid. And then the service that is required to support the use of that assistive technology. And again, that can be training, repair, service coordination, customization, maintenance, all of that sort of stuff. Schools are obligated under special education to provide assistive technology if it's required as a special education service, a related service, or supplementary aid and service. And again, those can also be things under 504. If the basic standard is that if the device is needed to help the student make progress, either in IEP goals or in the general curriculum, that is something that would normally be required. That's the standard. If the student doesn't get this device, are they going to be able to make progress on their IEP goals or in general curriculum? This is something that I think schools often don't pay much attention to. As part of the general evaluation process for special education, a school is required to do an assistive technology evaluation if there is any indication that some assistive technology might be necessary. This is something that often, when schools are doing their general evaluation and planning around IEPs, this is a piece that often gets ignored. And it certainly is appropriate for parents in an evaluation and planning team meeting to say, hey, are you doing an assistive technology evaluation? Are we looking to see what we should be having to provide support for the student? Now, there's no formal requirement, and I'll get to that in just a second, about what that evaluation looks like, but schools are supposed to be doing it. The question came, should the evaluation, the AT evaluation, be on the evaluation plan? Yes, and if the school isn't doing it, ask for it. It should be written into that evaluation plan. And who does the evaluation? Actually, I'm going to get to that in the very next slide. Let me just finish this one slide here. So again, schools should be providing materials in alternate formats, and that's something that sometimes don't think about it as assistive technology, but something as simple as providing larger print materials or something like that. So the next slide. So on AT evaluations. So because who does the evaluation and how are evaluations done? The rules are silent on that. There is no requirement for how it gets done. So you can actually bring in a specialist and hire somebody in, and if it's a particularly complicated situation, that would probably be appropriate. But there's no, it can also be done in-house and normally would be, if it's depending on what the type of device is. If it's a communication-related device, typically it's going to be the speech-language pathologist from the school who's going to do that AT evaluation. And that could be just a couple of paragraphs in their general SLP evaluation, but they should be paying some attention to that assistive technology. But again, it could be anybody who is qualified to look at it. Quite a few questions coming in. Question, what's the difference between evaluation and consideration? I don't know that there is a formal legal term of consideration. It's just you have to look at it and decide, is this something that should be provided? I mean, the team should be looking at it.
And can be appealed.
And it can be appealed. If you disagree, the parents can ask for an independent evaluation, and then the school does have to go outside to get somebody else to look at what should be provided. Where can parents go to get an independent AT evaluation? Again, depending on the type of device. If it's a communication device, ask the school for an independent evaluation from a qualified speech-language pathologist. If it's about mobility, then you look to a physical therapist. Whoever, again, is going to be a qualified provider in that field. And another question, if it's on the evaluation plan, Parental rights would allow an independent evaluation as well. Yes, exactly. Then if you don't like the evaluation that the school did, you have the right to request that independent evaluation and get somebody else to say, no, we don't. Yeah, we think that some other kind of device or should be provided. So all of that, I think, speaks to the school gets the first crack at doing the evaluation, but then the parents do have a right to ask for an outside evaluator if what the school is saying doesn't seem to meet the student's needs. Okay, next slide, please. So, assistive technology and FAPE, the Free Appropriate Public Education. School's obligation is only to provide AT related to educational mandates, as I said, reasonably calculated to provide some meaningful educational benefit. So if the student isn't making progress on IEP goals, one of the things you can say is, do we need to provide more AT support here? That's something you bring to the team and say, we're not seeing progress on this goal. What else do we need to be doing? But it does not have to be the best or even the most effective. Schools can look at cost as long as what they are, what they are providing meets that reasonable expectation of some benefit. Then they might provide something that may not be the optimal one, but they'll still meet their legal obligation. So what we're saying here, there was an earlier question about what, who determines, what's the best device to provide. If you have an evaluation that says, well, the student could use this and get some benefit, you get a doctor or an SLP does an evaluation that says you get some benefit out of this device, but you'll get more benefit out of that device. The school may only be required to provide the less effective device, but Medicaid might be required to provide the more effective device. So that's something to think about in looking at those, that the standard for the more effective equipment may favor looking to Medicaid rather than the school, as long as what the school has to provide is adequate. So those two standards can often play off each other in complicated ways. So a couple of questions here. What if the IEP team never discusses this? Bring it up at the meeting. If they don't bring it up, the parent has the right to raise it and ask the team to consider it. And if the team refuses to consider it, that's a basis for, at a minimum, an administrative complaint and possibly due process. But that's really a procedural failure. If the team fails to consider something that the parent asks them to consider, that's a flat-out violation and could be the basis for a pretty simple administrative complaint. So a couple of others here are, because lots of parents don't know it exists. That's why we're trying to tell you about this. Typing and fluency in AT appropriate IEP goals. Typing goals can be. The student has occupational therapy problems, really can't write with a pencil, and certainly keyboarding skills can definitely be something that would be covered. So both the keyboard itself and training in how to use it would be appropriate assistive technology. Do schools ever write these goals? And do they show up on IEPs? They often not, but they should. These things, and I'm going to say this a little bit later, these things really need to be written into the IEP because that's the best protection that you have. Keep hearing AT referred to as devices. Is it only limited to devices? There are two, again, going back to the definition, is the assistive technology device, which is the thing, and then there are assistive technology services, which are all the supports to provide to help you use and make, get the use and training out of the device. So yes. Okay, yes, let me get back to something. We have quite a few slides to get through here. The standard IEP, I think, this is back to AT and the IEP. Let me get the next slide here. So where, again, schools' obligations to provide the educational services. So as I said, it's essential to specify the AT needs in the IEP. You should really be putting that and asking the IEP team to write the AT needs into the IEP. The standard form that Vermont uses doesn't include a specific place to list AT. It has a place to list accommodations, and that's often where these things wind up. It typically doesn't fit into the goals, but it could. I mean, you could certainly write it in. But where it shows up most often, I think, is in the accommodations list. And that's and that's as effective as any other place, I think, as long as it's written in there. And it can be listed if there are AT services, if somebody is providing that training or monitoring of the functionality of a device, that should be listed on the services page. If it's somebody's time to be working on the AT, that can be listed on the services page with actual, how much time per week is being devoted to this, and it's a very good idea to do that. And include training for parents, as Marilyn is rightly pointing out, that those are things that can be provided on the services page and should be listed specifically. Okay, so the next slide on ownership of school AT. As Marilyn pointed out, Medicaid, when Medicaid buys a piece of equipment, it's owned by Medicaid. That is equally true of the schools, and schools are significantly more aggressive about this point than Medicaid has ever been. Schools own the devices and they want them back. Because they will reuse them, and they keep very close track of it. So typically the device is only used in school, and that is part of that ownership by the school. The school keeps the device, and even if it is allowed to go home, it's the school's device. There's nothing in the rules about liability about if it's damaged, but I can imagine that coming up. If a device is willfully damaged by a student, the school might raise that question. Question here. Student uses device, school. Shouldn't the student also have access to school for homework? That is the next slide. Home use of school AT. There is a rule that specifically says that on a case-by-case basis, the use of school-purchased assistive technology in a student's home or other settings is required if the student's IEP team determines the student needs access to those devices in those settings in order to receive a free appropriate public education. So using the device to do homework may in fact be a good reason to do that, and it is possible for the team to make that determination, but it has to be specifically made by the team. So again, the parent or advocate should be saying to the team, I would like my child to bring this device home so that we can work on these educational goals while we're at home. That's how you phrase it. Not just because we'd like to use it at home, that's not going to get you there. You have to be able to say, because we want to use it for this goal and this goal and this goal, or to make progress in the general curriculum. We need this to get the get the homework done. So if it's that iPad that you're using to help with things, that may certainly be a reason to do that. Says, when a child graduates and the school keeps the device, can VR provide the same thing? Typically, Voc Rehab very often can provide the same device. Let me give you an example, though, of a question where this came up. I remember in a case where a student had a hearing loss, and the school had provided an FM system where the teacher had a microphone that broadcast directly to the student's hearing aid, and the parents wanted to bring it home. Because it would also help out at home. But it wasn't going to be used at home for educational purposes. It was just going to be used at home to help the parents talk to the child, and it was just a very different context, and the school was saying no. As it turned out, Medicaid paid for a second system. We were able to get Medicaid to agree to do that, but we couldn't get the school to do it because it wasn't going to be used for educational purposes. So that's the bottom line standard, is that you have to define what's the educational use for it to be brought home. And if you can do that, then then it's not so much a requirement, but the team is allowed to permit that in a case-by-case basis. As always, there are going to be disputes over use of AT or whether the school should be providing it. So there are informal ways to resolve these disputes. So if the school has not done a formal evaluation, you should request one. Don't assume that the school is going to do it. Really, this is something you got to push schools on very often, and just got to bring it up. So if it hasn't been requested, it's harder to make the case that they should have done it absent the request. So it's always good to make the request.
What does a formal eval look like?
What does a formal eval look like? There's no set form for it. It doesn't even technically have to be on paper. Somebody has to have looked at it and made a decision about whether or not AT was appropriate in a particular case. It's better to have it in writing, and again, I would recommend that parents ask for one in writing because it's always better to have it. But again, whether it's incorporated into an existing evaluation or a freestanding thing, there's just no regulations around that. If there's been a formal evaluation but you disagree with the result, you can ask for the independent evaluation. If those tactics don't work, you can ask for mediation and just sit down with folks and try to work it through that. You can contact the Agency of Education. They will provide a mediator for free, and it's often one of the better ways to get these things resolved. If that doesn't work, then you can use the more formal resolution procedures, administrative complaints, and again, if they're simply not following the rules, if the school is simply refusing to consider it, an administrative complaint might be a good option. Or you could go to due process or even a federal civil rights complaint, especially if the failure to provide that assistive technology is preventing the student from accessing the school environment and resources. A couple more questions here. Where does one obtain forms for medical durable equipment requests? It's
the provider.
Yeah, I think this is the medical provider. The doctor should have
the medical store, hospitals,
medical store.
rehab centers.
Yeah, anybody who's a medical provider, who's a Medicaid enrolled provider, should have all the forms available to make those requests. And so again, I think those formal dispute resolution processes are always available. I think sometimes I just let me give one quick example of a case where I think it can be difficult. There was a case I was aware of where a person was requesting a particular communication device, and what it came down to was really a dispute of educational theory about whether it was better for the student to have this device to facilitate communication, or whether that was, I think some of the providers at the school were arguing that they wanted to encourage the student to be more independent in verbal communication, and they thought if they provided the device, it would not motivate the student to use his speaking capabilities more. That's a very tough thing to decide, and you have to have very strong expert opinions to support, if that's the nature of the dispute, you have to make sure that, if you're advocating for use of a particular device, that you have very clear support from experts about the necessity, the educational necessity or medical necessity in a Medicaid context for use of the device. We've been talking about this a little bit all the way through of school versus Medicaid, but just to summarize, Medicaid is payer of last resort. Medicaid is, only pays after all other insurers have paid. So if there's private insurance, Medicaid pays last. We've certainly seen disputes where the school or Medicaid is saying, well, why isn't the school paying for this? Which is kind of a red herring, because if the school is paying for it, they're going to try to bill it to Medicaid anyway. So typically, Medicaid is paying anyway. There's a question here about parents who have private insurance, if it's easier to work with medical providers than going through special education. It varies. If there's private insurance, Some private insurers are pretty easy to work with, and some are a nightmare. And I've seen
Same with schools.
I've seen it go both ways. It's if you have private insurance, you have to go to the private insurance first before going to Medicaid. But that doesn't apply to schools. But again, we're talking medical versus educational necessity there. Another question: are there any new requirements for private insurance in the area of AT around health reform law? I'm not aware of anything specific on that. The new law has, the essential benefits, and that'll include wheelchairs and basic AT, but I'm not aware of any other specific issues that are around there.
No.
And then another question: school district responsible to pay for kids who are homeschooled or in private schools? No, there's no obligation there. Districts have a little bit of discretionary money to provide services for those for students who are homeschooled or in private schools, but there's no legal obligation to provide in those cases. I think, though, I guess I would just caution people that there are situations where there'll be a little bit of jousting between Medicaid and school districts about who's providing, and I think that can often get a little sticky in some of those situations. There's one other point I just want to make from the slide here. The school districts must provide or pay for services in a timely manner when other agencies fail to provide. There's a federal law that basically says that if somebody's getting caught between the two agencies, the school should provide it, and then the school can do what's kind of called a pay and chase, and then try to get Medicaid to pay back, or whoever else might have an obligation, and seek reimbursement for Medicaid. But there is a provision of the law that says you're not supposed to get caught between the two. And we've listed the federal statute that requires that. And if things are getting bogged down in those debates, it's a good idea to maybe wave that law around and say somebody's got to pay for this, and then we'll provide the service, and then we'll figure out who should be paying for it after the fact. So again, we have our resources page here. We're getting a little over our time here, but I want to make sure we have that information.
And
We've had a chance
slides
to.
will be available.
Yes, all of these slides will be available online. We will, to anybody who's registered, there will be an email that will be sent out that will provide a link. I believe that the sound is also going to be available on YouTube along with the slides. So we'd like to thank you for joining us for today's webinar. The webinar will be archived on the Vermont Family Network website, along with many other previously recorded webinars. Be sure to visit Vermont Family Network's website at www.vermontfamilynetwork.org for a complete list of upcoming webinars, workshops, and support groups. Thanks for your participation. Lots of great questions here. Don't forget to also, if you have questions about any of the stuff, you can call Vermont Legal Aid and see if we can get you referred to the Disability Law Project to answer any further questions, or if there are particular disputes either in Medicaid or special education. Disability Law Project is often able to provide advice to folks in these situations. So thanks for your participation. Have a great day.